Hello and welcome to Fit After 40. Our guest today is Nick Moore. He's a doctor of physiotherapy and a partner at Resilient Physiotherapy in Sterling, Colorado. Nick, welcome.
Hey, thanks for having me on. It's good to be here.
Let's jump right in and talk about your practice because I know that you deal with sort of the recovery side as well as working with some athletes. Can you tell me about those two aspects?
We started Resilient Physiotherapy and Performance about little over 2 years ago. We are a mixed payment model, so we have cash-based patients. We take Medicare. So I really see the spectrum of actually I have pediatric clients from 2 months old all the way up
Wow.
to people in their 90s, and we've seen some college athletes from the local JUCO here. And so it's just a really nice broad spectrum, but we also offer performance and wellness packages as well. So we work with people who aren't just injured, but wanting to just improve their day to day living, whether that's running, or I had a guy who did strongman competitions, any number of things.
That's wonderful. Uh, so so let's jump right in with general advice. Let's say that I'm a guy who's just trying to get fit. I'm in my 40s. So what blend of strength training and cardio do you usually recommend for just your basic couch to 5K kind of guy?
Strength to cardio. Well, so when you look at a minimum, when you look at the exercise recommendations for most people, like the ACSM and that type of thing, they're looking at you're wanting to get 30 to 60 minutes of moderate to vigorous intensity exercise most days a week, right? That's like your baseline. But then I always say, what if we've seen anything from CrossFit, and I used to do CrossFit, I don't anymore, I like it, but if anything, we know that increasing strength, you can also increase your VO2 at the same time. So your lung capacity simultaneously. When it comes down to it, the stronger you are, the less effort you have to use every step of the day or even if you're doing a 5K. So even if you're kind of muscly and you have the VO2 capacity, you can do that 5K pretty easily. Now, I always say that it just depends on your goals, right? So if you have Gladys, who's 85, who just needs to carry groceries into the house, like she might only be able to lift 5 pounds, maybe 25 pounds is their max. But if you're 40 and you're wanting to run a 5K, being able to squat body weight's always a good goal. I think deadlifting, is 1.5, 2 times your body weight, is what I like to see in people. But it it depends on the goals, I think.
Yeah, oh, of course. So, so focusing on endurance athletes, Tony and I both tend to focus on endurance sports. He does
Mhm.
ultras, and I do some running and do some cycling. How many days a week of strength training would you recommend for guys like us?
So the research has shown that you can increase your strength training in 1 day a week, but you have to
Okay.
hit a sufficient, yeah. So it just depends on your schedule, but 1 day a week is hard because you have to hit a sufficient like training volume in order for you to hit adequate strength gains. So you need to be lifting upwards of 80 to 85+% of your 1 rep max on those lifts in order to start seeing those strength gains and getting that muscle breakdown, if that makes sense. But typically what is more well tolerated is 2 to 3 days a week. Just because you can break it up, you wouldn't have quite as much soreness because you can break up that total volume, if that makes sense. And you're looking at 3 to 5 for true strength training. You're looking at anywhere from 3 to 6 sets of maybe 4 to 8 repetitions. Like it's pretty low repetition, but it's high intensity, high weight, relatively high percentage of 1 rep max.
Okay, so something we could do a couple of times, so you don't risk hurting yourself, maybe. But 20 reps, you're not going to see a whole. If I'm doing 20 reps, I'm not going to see a whole lot of benefit at that point, am I?
Well, so you can. It just depends. So in college, I attempted to compete at a collegiate level, right? Um, And in college, what you start to see that they do better than in high school is what's called periodization. And I don't know if y'all talked about on this podcast, but that is just the principles of tailoring your training over the year to consistently make gains. And what that means is that during specific times of the year, you're doing different types of training. So like if I was in a couch to 5K, I'm not going to start off just running 25 minutes. I want my tissues to start to be able to handle loads. So I'm starting to do walking, and I'm doing a progressive walk to jog and walking. So those interval type trainings. Strength training is very similar. So you would see those higher repetitions earlier on in the training cycles of like, we call it an adaptation phase, if that makes sense. Because your bodies adapt. You develop calluses, your brain mapping can change, your nervous system changes, your muscles change, your tendons get increased tensile strength. And that all comes through the repeated loading. What I wouldn't recommend is just jumping into high load training. You do need that actual higher repetition early on to help your tissues adapt. And it can be, I don't know, I would say a few months. So that's probably a better way to say it. It's a few months of getting that adaptation phase before you really want to start hitting the higher loading.
Do you mind running me through a sample? Let's say you got somebody who's not in terrible shape. They've done a little strength training. They can probably run a 5K, but they're really looking to really chart some gains. Could you run me through kind of a sample routine of what you might put them through?
A sample routine for running or for strength training?
A combination of both, if you don't mind.
Okay. Yeah, so I think the way that I typically recommend things for people is that you're going to be running more days of the week than you're not, but it may be shorter periods of time. There's a physio up in Canada named Blaise Dubois, who it's the runningclinic.com. I've used a lot of his programs because I think he has a real good eye on how tissues adapt. So he actually has people running up to 6 days a week, but he's often doing these like progressive walk to jog programs.
Okay.
So in that, then with strength training, I have people doing a lot of posterior chain exercises. So pretty traditional squatting, deadlifting. Then if they're needing that power, cleans, Romanian deadlifts. And that's probably 2 to 3 days a week, depending on what their schedule is going to look like. Those strength training sessions, I prefer multi-joint muscle work. So I actually enjoy, and I'm biased, I think. You can get adequate gains from using machines that isolate muscles, but it just takes longer. It's less functional. You're not upright. You're not weight bearing. You're not having to challenge your balance. And so, there's an efficiency standpoint of being in the gym and hitting, your power cleans, but there's also a high technique aspect to that and needing to be taught to do it well. So, but typically those strength training sessions will last, 45 minutes to an hour, maybe an hour and a half. Running could be anything from, if you can run a 5K, then you can probably easily, most people's 5K is anywhere from probably 20 to 30 minutes, right? Some longer, some shorter.
Yeah.
But, then you're just looking at gradually increasing those times systematically, depending on their goal.
So you've kind of touched on it a little bit, but maybe now is a good opportunity. Of course, we have different kinds of muscle fibers, and those muscle fibers have their corresponding metabolic pathways. Do you mind just real quickly, defining type 1, type 2 muscle fibers, and just a little bit about how quickly those are going to become fatigued, and when we're going to switch over to the slow twitch kind of thing, just so people know what they're looking for when they are working through this training routine.
Yeah. So I guess really quickly, you would see well, it depends on how you want to divide it up, but there's type 1, which is your slow twitch fibers, and then you have type 2, and there's, if I remember correctly, there was like type 2A and B, and then there was an X group, kind of an intermediate group. But I think very quickly, your energy systems, you have one that's going to take you up to about 10 seconds, and that's just like complete fast twitch. But then there's one that is more resilient to lactic acid a little bit. And that's going to take you up to about, that's what you get these guys that are running like the quarter mile and that type of thing, and the half mile. They're running at it almost like they're running at 95+% of their max,
Right.
so I'm thinking usually that's around 2 minutes of time of pretty much max effort is going to be your trending away from that. Well, it's just that it's a type 2, but it's a different type of type 2. So I don't know if that's helpful to differentiate, but they're different systems. And then the type 1 is kind of anything that's going to be that you can sustain. And I always think that this is like your mile plus group.
Mile to ultra marathon.
Right. Yeah. And the reality is they're all working in concert, but the beauty of it is that the stronger that your cardiovascular system is, but all those are trainable, right? And if your turnover, so your cardiovascular system, your lungs, all that is more efficient and has more volume, it can create a better turnover. That means that your anaerobic, like glycolytic system, that kind of like 90-second system, can actually last longer. And that's what you see in these freak Tour de France athletes and some of these guys that can just push that high power output. They've trained
climbing a mountain.
Right. Yeah. They're insane, but they've also trained it.
So, along those same lines, to kind of bring it to what this podcast a lot of times is about, when we're talking about those muscle groups, what are the effects of age on those different muscle groups, and how should we adapt training around, when you are reaching middle age and beyond?
Yeah. I'm not quite 40, so I'm almost age appropriate for this podcast. But as what we generally see, starting, well, from the baseline, if you don't use it, you lose it, right? That's just a physiologic principle of muscles. What you're seeing with atrophy is just a decrease in cross-sectional area of the muscle, regardless of muscle type.
Literally
what we
smaller.
notice, literally smaller. Yeah. Now, as we age, you see that general atrophy, and I'll be honest, I'm not quite sure if it seems to target your type 2 muscles, Tony. And what we see is just generally strength, like that global strength loss. So I'm trying to hopefully answer your question adequately. And typically what that happens, that it's postmenopausal for women. That's when it really starts to hit pretty heavy. And then for men, it's going to be, typically we say 50 to 55 is when that really starts to hit. Before that, what you tend to see is more disuse, atrophy, to be quite honest.
Okay.
Because we're just not as active from 25 to 45/55.
Gotcha.
People go to the easy chair and the recliner, and they're not hitting the gym quite so often.
Well, we're working age, right? So
yeah,
and most of our jobs are not as active as high school athletes at a minimum. It's just depends on what you do. But Tony, did that answer your question though?
No, that was good. I was just kind of wanted to bring it into that. That was interesting too, because you said it was from 40 to 45. Really, there's not a whole lot of loss there, or it's mainly a lifestyle thing, which I think is an interesting thing to think about, because some of us that have started do a lot of running now probably do more running than we did when we were younger, and it's actually a little that was a little bit of hope for me there. So
far more
that I'm doing the right thing.
Yeah, I think what you see though, Tony, is our recovery rates at this age aren't as good.
Okay.
So that, and that's just cell and mitochondria, like the aging process itself. We've demonstrated that people can get stronger well into their 90s. Like, so we do deadlifting and relatively heavy lifting with people above 90 all the time. Mm-hmm. But you have to be more cautious about delayed onset muscle soreness, about recovery time frames and things like that. You just need to be more cognizant of that, I think, as we get older, because like my daughters are 3 and 6, and they have their tonsils out. Now, you and I would be laid out for a week and a half, and they're
Yeah.
like, they were WWE wrestling yesterday afternoon, 8 hours after the procedure. That's just the blessing of age, right? So
Yeah.
Right, right. So while we're on the topic of recovery, obviously you don't get stronger, you don't get faster during training. You get stronger and faster while you're recovering, right?
yeah, sure.
So, do you mind talking a little bit about active recovery? Me
Mm.
myself, if I'm taking a rest day, I still often like to go for a walk, maybe a brisk hike. What do
Mhm.
you like to do on rest days? What do you recommend that we do on rest days?
So there's a couple of different things. I think some of those. Well, I'm trying to think of how to answer this. What I was thinking was going through my head was there's a lot of the wearables and things like that
Sure.
are actually really nice, that are looking at what is your heart rate recovery looking like, and overall sleep and stress and all these
Let,
things. Those are
let's talk
all
about that.
phenomenal. Yeah. So
Yeah.
at a minimum, you need to be up and getting some total body exercise. Say you did a really, oh, say you did a really high intensity run, and you followed it with a high intensity total body workout. You were doing, say you did deadlifts, and then you did cleans, and then you did like snatch. Snatch is one of my favorites, which everybody hates it, but it's awesome. Um, and you just worked yourself hard. Now, for me, like delayed onset muscle soreness usually hits around 36 hours, and that's different for everybody. So, but I know that flushing that system, getting your heart rate going for anywhere from 20 to, I would say, 30 minutes, getting it moving, taking your joints through full range of motion, you need to be doing that at some point throughout the day. And
Okay.
and again, like, is it swimming? Is it just going for a walk and doing yoga? But you need to get your heart rate up. You need to get the blood flowing, and then taking joints and muscles through full range of motion to flush the system. And that can look different for every person. And I will say that everybody's that delayed onset muscle soreness, their chronic fatigue, their capacity before they hit like chronic fatigue syndrome and that type of thing is going to be different for every person. Does that make sense?
Mhm.
Absolutely, absolutely. So while and if you have a wearable recovery workouts, I mean, we're talking zone one, zone two type of cardio, correct?
Yeah, yeah, absolutely, yes.
50% of your
hmm
max heart rate to 60%. Is that about the range we're
hmm
looking at here?
Yeah, I would say so. Yeah, you're not going to be wanting to like push it. So that zone two is probably the max
Yeah,
you'd want to hit.
gotcha. And for people who don't use wearables, we tend to divide it into 5 heart rate zones. Zone 5 is essentially your max, more or
hmm
less calculated by subtracting your age from 220, and then it scales down from there. So,
Right, and that's what we all know that's a proxy measure. I still use
sure.
it, the Carbonian formula. I still use it because it's a good easy go to that we can then modify from there.
Right.
And that heart rate recovery. If you've watched it and you've tracked it long enough, the the rapidity with which your heart rate recovers is one of your best indicators of, and we this is pretty widely known, but is one of your best indicators of how your recovery is doing.
And when you say recovery,
So,
you mean how quickly it returns to your resting heart rate after a workout.
oh yeah, yes, correct. Sorry.
When we're talking about recovery and wearables, just out of curiosity, what are your thoughts about these? Like I've got the watch on here that we all have them on, and it's going to tell me, after a workout, you've got 48 hours till you're recovered and so
hmm
on. And then, maybe I have a restful day and it's like, hey, your recovery has gone down by 10 hours, or whatever. And
hmm
it keeps on
hmm
giving you. What do you think about the accuracy of these devices that people are using on a pretty regular basis? Is it something we should swear by, or is it semi made up information? I don't know.
I like I said, like most of it is kind of proxy measures, so and I'm not familiar with all of them. Um, During my fellowship, we always kind of said garbage in, garbage out. Like if you get garbage information, the data is
Yeah.
not super useful, right? And I think that's getting to the heart of your question. Um, it's better than no data. I think like we said, like the heart rate recovery, O2 measures, I think those are kind of good indicators of just how your system's doing. I would say, like, and I'm trying to think, your sleep quality is huge in that. So if you're thinking like you're still sleeping like garbage and and your heart rate's not recovered first thing in the morning at the early part of the day, even if it says you're recovered, if you feel like garbage, there is that intuitive piece to it as well. So I always take them as it's a good additional piece of information. And you're pairing that with what is your whole. So I always think of like recovery and training as dynamic, and that's been starting to be a lot more looked at in the last 10 to 15 years. Is your training is not just your run and your lifting. Your training volume also has to do, like, did you go for a huge hike with your kids the other day? Did you sleep well? How is your stress at work going on? Because all of those things influence your recovery rate. And that's been, they've looked at that a lot more in like college athletes and professional athletes, like looking at overall lifestyle stress and the ability to recover, and trying to modify, some of those things you can modify, some you can't. But the modifiable factors can really influence your ability to recover. And that's been a really cool area to like look into, is just stress biology.
So maybe to some degree, while you wouldn't want to swear by the numbers, it does give you a tool to look at trends, general trends.
Oh, for sure. Yeah.
Yeah.
Yeah, absolutely. And I say that, yeah, I didn't answer your question well, but to look at the trends, to say this is another additional piece of data that's giving me physiologic data that I can pair with how am I feeling, and then pair that with like what is the overall volume of like my life look like at that time and place, and I need to make the best decision based on all that data.
So while we're on the topic of recovery, talked a little about active recovery. What about other strategies? For example, do you use a cold plunge after a really hard workout, or heat, or do you do anything like that to aid with muscle soreness and recovery?
Well, I will say, so I used to in college, and obviously we live in Colorado, and those cold plunge things are just. I mean, I think the idea is great. If anything, it makes you tougher, and your ability to tolerate discomfort changes, which I think is worth something.
Oh, absolutely.
But cold is an analgesic. You do have the physiologic responses. I think if you find that it's helpful, if your cardiovascular system it can handle it. So that's like, there's a medical caveat there. I don't think it'd be recommended for everyone, certainly. I think it can help with the muscle soreness. And I did it in college. I don't currently, I don't have a cold tub, but it's, a couple of weeks ago, it was minus 30 outside. So I just walked outside.
Walk outside for a moment, yeah.
Yeah, so I think they can be useful. The data is it's just hard to study that really well. Typically in the past, studies on heat and cold have been mixed.
Okay. What about cupping? Have you seen this? A lot of the elite athletes are doing cupping. Do you think there's any benefit to that, or is that just snake oil?
We know from the bruising that it can cause tissue damage, right?
Right.
So it's actually doing something to the tissue. Yeah, visibly, it's lifting the tissue. My baseline would be to say that you're getting a neuromodulatory effect, and by that I mean is that you're changing the sensation to that area that makes it more comfortable and more tolerable at a minimum. And that can maybe help you perform better, but it's transient, right? So it's not going to last for forever. You're getting, obviously, because of your bruising, you're getting blood flow to the surface. You're causing some type of tissue damage. Is that helpful? When we looked at dry needling, if you're familiar with that. So there was a pecking, there was like a pecking technique where they tried to cause an increase in blood flow to tendons to try to induce like a restart a healing process. And at least for dry needling, that didn't seem to be helpful.
Okay.
Now, I think the neuromodulation is helpful. I'm not sure if like there doesn't seem to be a huge benefit to like getting all the bruising, kind of like the gua sha stuff.
Sure.
So I see cupping on the spectrum of like massage therapy.
Okay.
And hopefully
And
that's not
massage,
like super offensive to anybody, but
you know,
yeah,
one man's opinion.
yeah,
But massage does have some benefits. You know, if you've done a hard
yeah,
workout, a massage increases blood flow and can
yeah.
help with knots and so forth. I mean, there's some real benefits
Mhm.
to that. Do you use that in your practice?
Yeah, so we use dry needling predominantly. And again, they're all running along the same spectrum. They're working on the soft
Okay.
tissues, they're having local effects, but they also have an endogenous opiate release, which is like your runner's high essentially. So they have a pain modulating effect that doesn't need to be discounted, but most of their local effects are transient. So that increase in blood flow, that increase in tissue extensibility and flexibility, manipulation actually, so like having your back manipulated or your neck has a very similar neurophysiologic effect. You're not changing the position of bones necessarily, but you are changing muscle firing around those joints. You're getting an increase in blood flow to that area. You're getting a transient change in mobility. And we see similar things across the spectrum with those like soft tissue mobilization, or if you want to call it massage, or we see that with dry needling, and we also see that with things like cupping as well.
I know I go to, I'm a strong believer in acupuncture. I've had a lot of good experience with it. I guess dry needling, same thing essentially.
Similar, yeah, very similar.
Similar. And I know my acupuncturist sometimes uses cupping for just people that are afraid of needles.
Oh, for sure. Yeah, absolutely. There is so I don't have the cupping stuff, but I'll use different techniques if people don't want to be dry needled. I think the dry needling has a more immediate response. It's deeper into, obviously you're getting down into the tissue. So there's I would say a more pronounced response to that typically. But yeah, if somebody doesn't want to do needling, and I do the same thing, if somebody doesn't want their, they say they've got neck or upper back pain and they don't want a manipulation, I can do other things, or whether it's dry needling or just soft, like a gentle mobilization. So there's a individual variability there.
Absolutely. Yeah. And what I will say about needling or acupuncture is, I mean, yeah, there are those moments when you're having that done where there's just kind of an aha moment almost, they get it just right. And then it's almost instantly better.
Yeah. 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 So I typically will tell people that it is often helpful, but it is not a silver bullet. It's not for everyone. And it's not the only thing that we can do. So those things are pretty case by case basis for me, at least treatment wise. Yeah.
While we're talking about treatment, I think a lot of people don't necessarily know where the line is between, if you run a marathon, it's going to hurt. You sleep funny, your neck is going to hurt. And there is a line between your normal aches and pains and something that does need attention. So what should we look for when we're trying to determine that line?
Yeah. So the way that I typically, we want to normalize pain, right? Like pain is a normal part of the human experience. If you don't experience pain, you either have a congenital issue.
Right.
And I always tell my older patients, like, you'd be weird if you didn't have some aches and pains. So that being said, there's a lot of injuries that we don't have a good natural history for, if that makes sense. Like, we don't know what it really looks like without intervention from start to finish. That being said, what I typically give people is categories, like, are we better, worse, or the same? So like, say I get a crick in my neck and I'm like, oh, I've got the spasms. I'm not sleeping well. My own threshold may be higher than some, but again, the medical knowledge says like, I know that there's no red flags. So say if there's neck pain, like I haven't fallen, I haven't been hit by a car, I am not, having like weird neurologic symptoms, numbness and tingling in my hands. Right. If there's no red flags, no overt like trauma for which I need to go to the ER, then I'm going to give it a couple of days to like calm down, and know that there's usually an inflammatory process going on. So sure. PTs, at least non-military PTs, can't prescribe large doses of ibuprofen or NSAIDs. But, if there's an inflammatory process, the evidence is mixed about like that process is there for a reason, right? So we want to control pain as much as we want to control that inflammatory process early on, because the inflammatory process is helpful. Now, that being said, if you can't sleep, it's not super helpful. So one of the biggest things is you want to be able to sleep well in those initial stages of recovery. And sometimes those are mutually exclusive, that inflammatory process, especially for spinal type things, and even in knees too, and hips, because you're not moving. And so that inflammatory, that inflammatory cascade and all those things are sitting overnight. There's a secondary hyperalgesia that occurs. So by that, I mean that like the inflammation and those chemicals and things that make up the swelling in an area actually cause a secondary irritation and sensitivity to the tissues around that area, if that makes sense.
Okay.
And so anyways, where I'm going with that is you need to control pain as much as swelling early on. And then if within the first week or two, if you are getting better, even if it's slight, if your range of motion is getting more full, if you feel like your pain is more controllable, I'll typically tell people to like, let's just keep watching it. And that's what I do for myself. Now, if it's getting really, really getting better, then don't worry about it. Give it a good couple of weeks and just get back to your normal activity slowly. Yeah. But if after, 2 weeks is probably the minimum I would wait, unless there's red flags. If it's starting to get worse, if you're starting to get a loss of range of motion, if you're starting to have broadening of symptoms after that time, then typically I would say you could start by seeing either a PT or a rehab specialist of some type. Right. I don't want to like say that PTs are the only ones to go to. Now
but
it depends on where
in this.
We do. Yeah.
PTs are specialists, and you do go to school for a long time to be that specialized. So
yeah. So I'm rambling, but it's kind of a hard question. And to say like meniscal, and let's say the knee, for instance, that's an easy one. A friend of mine has started playing racquetball. Yeah, runners. A friend of mine, he's 42, started playing racquetball with a much higher frequency and intensity. He's starting to have some anterior knee pain. So front of the knee, probably patellar. He's a big, tall, 6'4" dude, and he's the shortest in his family. So kind of predisposed to some of that anterior knee pain. What I would say for him is he has a couple of options. He could take some NSAIDs and kind of just mask that inflammatory cascade. He could lower his frequency and intensity to a point where his body will tolerate it, but he's still active and still playing and still doing what he wants to do. Or we could always bring him in and take a look and see, like, are there some muscular deficits and things like that he could work on to maybe make him not so prone to that injury. Now, but the long and short of it is part of that might be just a progressive load of his anterior knee. So like progressive squatting at an angle and things like that.
So exercises, specific exercises to strengthen the joint.
Right. So, but for your normal person, and I tell this for my patients, if it's just rapidly getting worse, then see somebody, whether it's your primary care doc. The hard part about recommendations for that is what the data has shown is where you start often dictates the type of care and where you're going to end up, more so than what injury you have. So if you go to see some healthcare professionals, you are more likely to end up with an MRI, end up on medications, be on the track for surgery.
Something we prefer to avoid, especially given the history of opioids over the past 10 or 15 years.
Yeah, and I'm trying to be a little sensitive and tactful to that, knowing that there's variability in regions, there's variabilities, and even within healthcare professionals. But largely, if you see a rehab professional, you're going to get a more conservative approach rather than
straight to the pills.
Not. Yeah.
So you mentioned some red flags, and specifically you mentioned numbness and tingling. What about headaches? I ask because my wife is going to PT right now. She had some neck and shoulder issues that started translating into some pretty nasty headaches, and at that point she started going to see a PT, and her results thus far have been miraculous. But what other red flags should we be looking for? Are headaches on that list?
Well, headaches aren't necessarily a red flag. So like if somebody came in to me and said, "Hey, I'm having headaches," what we look for a couple of different things. Like, are the headaches mechanical? So that is, like, are they traceable to a position or movement that's repeatable? Like, and we can see that pattern. If it's a red flag if you're having accompanying like cranial nerve symptoms. So are you having double vision? Are you having hearing changes, smell and taste changes, inability to move facial muscles? Let's see what else, difficulty swallowing or speaking. Those types of things would be red flags for like associated with headaches specifically. Then you would also look for like, there is like some strokes or pre-stroke things would manifest as like a unilateral headache, but it's also these like headaches that are worse than you've ever had before. So
no ambiguity if you're having one of those.
Yeah, no ambiguity. And then, some headaches that are worse when you're lying down, that would be a thing where like your blood pressure to your head changes as you go down. And if that head and neck pain is maybe worse, then that could be a red flag. It's not always.
Okay. It's worth discussing with somebody if you're having that type of
symptom. So you're looking at those types of things. If you have high blood pressure and a history of like cardiovascular issues, it's an associated factor with like having strokes and that type of thing. So that would be something I would also kind of like look at, is like, what does this person's blood pressure look like on a day-to-day basis? Are they typically having high blood pressure, and then did they have a stressful event and they suddenly have this headache that's starting and it's getting real gnarly? Those are all things that we kind of look at as a cluster of symptoms that we might worry about.
Do you have any other guidance to offer? You've talked a lot about how we communicate pain. Like, I can't make the doc feel what I'm feeling when I turn this way. Do you have any other guidance on how do we communicate this so that the provider can really make a good assessment?
Well, the first caveat is if the provider is listening to you, which I hope they are.
Critical ingredient.
But often, unfortunately, they're not, as much as they should.
Get a second opinion. If they're not, get a second opinion.
Yeah, if they're not willing to, and I say that my wife is, as you know, is a physician. They have a lot more constraints on their time. That being said, so when you are going in, what I'm looking for is to give an exact location of pain, a descriptor of what does it feel like. Is it sharp? Is it dull? Is it achy? Is it just stiff? And then typically it will go into like what specific motions, movements, activities exacerbate those symptoms very specifically, and as specific as you can. And that typically, so a lot of folks will come in and they'll have had symptoms for, at least a few weeks. But what I'll typically look at is that, are these people having symptoms, like how is their pain looked over the last 3 to 4 days, maybe a week, depending on how long it's been going on, as opposed to how did it start? Because often how that condition started has evolved and changed such that it's not really the same anymore. So it's more important for us to look at like the last maybe week, and how is that behavior looking over the last week. The other thing that we always look at is like, how do symptoms change throughout the day, and are you having symptoms overnight? Those would be some other helpful things.
So for example, if I'm having symptoms when I'm hunched over my computer screen, that's probably a useful data point, but I don't have these symptoms when I'm up and moving around. Maybe there's something to be learned there.
Yeah, that's super helpful. Does it go away at any point during the day? And is that a pattern that we can depend on? That stuff is, and being aware of that is huge.
I guess to kind of switch gears out of pain now too. Well, I mean, still pain's involved in all of it, I suppose. So there's no way out of that. But to kind of switch gears into and how to avoid seeing you in person. Not that I would want to do that. What are your recommendations for runners? And a lot of our listeners are ultra runners, because I know a lot of our listeners. And so these are people that are running, at a minimum 30 miles at a time, upwards to 250 miles. And we get a lot of chronic overuse injuries in the process of doing that. So what are some of the exercises for people running, half marathons and beyond, to avoid some of those, falling into some of those situations?
When you look at the requirements of that, obviously I think at that point, having someone look at your running efficiency, it would be important, because every step takes a little bit of load, right? So the more efficient you can become, and having like maybe a running analysis, like it's super hard to like change. It can be really dangerous to change your running style. But that being said, sometimes having an analysis and looking at like where are some inefficiencies in how you're moving could be helpful, because then you're decreasing the relative stress with every stride. So that could then you could then take that data and say like, all right, is my hip dropping, or is my knee falling in, or doing these weird wonky things because of a muscle imbalance? Most often, Tony, I think people will harp on hips and trunk. So for me, hips and trunk I always say it's like if your hips and trunk aren't strong, it's like firing a cannon from a rowboat. That rowboat's going to go backwards, and your legs just don't have a stable platform to work from. Okay. So then your hips and your back and your hips and your legs have to be exceptionally strong. Now, from that standpoint, then you would want to start moving into those higher repetition exercises though. So if you're talking about strength training for these ultra endurance athletes, if they have the time and the desire to do that, you're going to be doing some higher load but higher repetition exercise. There is a trade-off with the ultra folks. I think the strength to body weight ratios are looking different. But that being said, like, always posterior chain, because that's what keeps you off the floor, right? So I'm thinking, your back muscles, your glutes, your hamstrings, gastrocs, your quads have to be exceptionally strong, because it's on trails, so you're going up and down hills.
Up and down.
That being said, too, there is some benefit to loading, like basically you're doing squats on like a slant board.
Okay.
If that makes sense. So your toes are pointing down, and getting your knee, so the knee, not only the tendon, the patellar tendon, and your quads used to that, but getting your kneecap and your patella used to handling that high intensity load of going downhill is something you could start to regularly integrate into your regimen, so that your tissues, all those tissues, get used to handling the forces involved in running up and downhill.
That's great.
Does that make sense? Yeah.
No, that's really good. Yeah.
Yeah. So, and that depends, like you could do that too, I guess, to a certain extent, if you're doing a lot of road running. And I know depending on where you live, some of the crowns on these roads are ridiculous, and so that adds its own kind of loading factor medially and laterally. So again, I always kind of go back to the principle that all of our tissues are adaptable, but they want a progression of that load. They don't want a really stark increase in that load.
There's kind of a slow. I think what I did in my ultra training is the slow dumb way, which would be
that'll work.
Just years and years of just going out and beating myself up in the woods till all those things kind of came along slowly. But I think the recommendations you gave there are good for people that maybe want to avoid all those chronic use injuries along the way. Because that is it. I mean, up and downhill like that, that's where you get a lot of that stuff. You get that all the way through your legs, your quads, your shins, and your ankles, and so on in your joints. So.
Well, and to that point though, you gotta, again, when we were going back and looking at like how are we recovering, you gotta find a way that you can get the same cardiovascular load. And I know this is, it's questions. Cross training comes to mind, right? So as we've already said, you can get a good cardiovascular workout through strength training. You're just doing it through circuits or restructuring how you're doing that strength training. But you're also thinking like, can I bike? Can I swim? Can I do a combination of those two, maybe rowing, to get the same cardiovascular load, but have a day where my joints aren't taking the pounding? If you need that. And as we get older, we've kind of said like that recovery becomes more important. So, is it that every third day you do a low impact day so that you're not seeing those cardiovascular like dips, but you're also not having quite the strain on our joints. And to that point, Tony, I think it is worth saying that, when we're looking at like development of arthritis and that type of thing, the stronger you are around the joint, the less of the force that goes into the joint itself. So like if that makes sense, like it's not, I didn't say that well, but the stronger the muscular system is around the joint, the more uniform the stress is on the joint. That's probably a better way to say it. So the stronger you are, the less stressful it is on your joints. But we also know that like people develop arthritic changes at the low end and the really high end of run. That's been pretty well established. So for you guys at that high end of running, having days where you can maybe unload for a little bit and then also getting strong could really potentially increase the longevity of your career in running.
Yeah, that's great.
And this is where you might recommend maybe spinning as opposed to running, right?
Sure,
you just take a day off of running, jump on the spin bike, go for a bike ride. Swimming is another good one, something along those lines. Is that what you're getting at?
Yes, that's what I'm getting at. So swimming, biking, rowing. To me, rowing is like I love it, but I think it just smokes me a little bit faster than the others. So and maybe it's novel. I don't know. Maybe that's it.
I like changing it up too. I get bored with the same stuff.
Yeah, but there's also aspects of like if you're going and playing soccer, that's also getting your joints accustomed to different forces. You're playing on grass. You talked to Tony about like shin splints. There's a decent amount of data looking at like shin splints usually occur because of a rapid increase in training volume. Like that's more often. Yeah. They more often occur because of a training error, not necessarily what you're doing. So again, just another plea for like having the muscles around, so it's like medial tibial stress syndrome is kind of the thing. Having the muscles in that lower leg strong, and typically you're looking at some barefoot training for that as well. You could be doing that. But then really paying attention for you ultra guys to training volumes and trying to reduce any really heavy spikes in that.
Yeah. I mean, with shin splints, that's a good point. We always talk about that. I'm not a PT or I have no expertise in any of this other than I like to run. But, amongst runners, we always, shin splints are kind of like a beginner injury. That's that's the first
Right.
thing. If I'm going to start running, the first injury you're probably going to get is that. So,
Yeah.
yeah.
Yeah. It's, yeah. And it's often like, it's pretty predictable. Now, that being said, some shin splints aren't always shin splints. Sometimes there's a muscular origin to that. And sometimes there's you would only know through imaging, but like sometimes it's more of a long-standing, like I said, that medial tibial stress syndrome where it's like a bone stress injury itself.
Mhm. The way you threw in playing games and stuff like that too. I think that's a really, especially for ultra runners, a lot of us really dread, mainly speaking about myself, but we really dread the gym,
Oh, sure.
and
Yeah.
and
Yeah.
and any kind of exercise machine because it's just boring. I was
Yeah.
anecdotally say I used to keep a treadmill at work here. I keep a rowing machine here at work still. I used to keep a treadmill here. I used it one time to try out a pair of running shoes I had. I thought I would use it all the time when it was cold and rainy out or snowing or whatever, but then I decided I'd rather just, no matter what the weather is, be outside than be on that treadmill. So if you can incorporate some of these cross training things in a way that doesn't feel like it's just you're inside having your soul sucked out. It's
Yeah.
Right.
Yeah. Yeah, and I think the importance of that too, though, is having, once you find some different things, if you do get an injury, every runner, every rehab professional knows the difficulty of treating a runner and the point at which you're like, all right, do I need to have the conversation of do they need to stop running
yeah.
in order for this to heal? It's not always a necessity. But if you have some of these other go-to things that when you're starting to feel it kind of nag, and you can maybe shift that to, or again, going back to that, like, do I need to see a guy or not? Can I self-treat by decreasing the relative load such that I can get a recovery and then start to like mitigate those things? And then once I give it a few weeks to kind of like calm down or cool off, then I can start re-engaging what I love to do. That's a good strategy to have in your pocket.
Mhm.
Tony, sounds like maybe you need to get that old bike tuned up, at least here and
I,
there.
I I definitely do. I have been doing a lot more swimming, of course, recently because Joy and I are entered in a couple of these swim run races, so I've got to work on that. So.
Yeah, I actually have my
Yeah.
first training session with my swim coach next week. So wish me luck. You can't really
Yeah.
dog paddle a triathlon. So, I mean,
Yeah.
I guess you can, but probably wouldn't post a very impressive time.
Yeah, one could.
Hypothetically. So you've mentioned a lot about knee and hip. Obviously trail running, one of the big hazards there, especially here in Pennsylvania where the trails are just solid boulder fields, turning an ankle.
Yeah.
Do you have some cross training, some exercises that would strengthen that ankle and help reduce that risk?
Well, so typically you're looking at your ability to react to a new event. I'll just say it that
Okay.
way. So yeah, so typically you'd be looking at doing balance work. So whether it's single legs, so honestly, doing some, integrating into your routine some kind of single leg squatting work. It's like mini squats or something like that. But single
One
leg
of my
work
favorites.
and moving up to doing that on like a foam pad or some type of less stable surface. Going back
Oh, wow.
again to doing it on a tilt board. So most people lose it laterally. So then actually working in that zone and having your muscles try to work where they're in a position where they're having to control that lateral tilt would be beneficial. So not only are you working that musculature actively through doing, like, you could just do normal exercises against a band or doing whatever,
Sure.
but then getting to where you're actually working in a zone where you're prone to injury, which would be kind of a laterally tilted position, and then also doing some balance work, single leg balance work. that would, I would say, integrate some like squatting, and would be where I would go.
Split squats are one of my favorite go-tos, and it's
Yeah.
validating to hear that I'm doing at least one of the right things here and there.
Well, and so once you're good on the split squat, then doing that on having like a Dynadisc on that, or a foam pad, something that's kind of less stable, and a level up, just to train your body to control it. And then, this goes back to your question, Tony, earlier about training ultra runners, doing some like control work when you're fatigued, and teaching your body to training your body to work under control when it's tired is really important, because when we start to get that fatigue point, towards the end of the runs, it's like on huge hikes, it's always, you're coming downhill and you're not paying attention and your body's getting kind of sloppy. That's when injuries occur. So you almost need to teach your body to stay tuned in the whole time.
That's a good point. Yeah, you start cramping, and I keep one of those, like, I don't know what you call them, like those wobble board things by my bed, you know? And like, so whenever I'm just bored or standing around, I just get on one of those and try doing my squats on the wobble board. But I never thought about incorporating it maybe after a run. Like, so go do a run, have that fatigue, and then go try to work on some of the stability afterwards. It would be probably a great idea. So.
Yeah. And that's one of your, when we talked early on about that periodization, early on, you'd want to do maybe your heavy running and heavy lifting on separate days. But as you start to want to like challenge your system more and train more towards like what your timed runs or your competition runs are going to look like, you want to induce that fatigue and then train your body to work in that fatigue, if that makes sense.
Yeah, no, it does.
Absolutely. So, Nick, thanks for taking the time to talk with us. I am kind of growing mindful of your time. I know you're a busy guy, but I did want to ask, we've talked a lot about specific to training, but a lot of us, myself included, most of my workday is spent hunched over a computer screen, and I do try to get up once an hour and do some stretches. But do you have any recommendations for ways that we can kind of work on the neck, on the shoulders, on the back, kind of those the discomfort that is related to that office posture?
Yeah, I mean, I'd say I'd work on that most days. So
right.
the mantras are always motion is lotion, and the best position is the next position, right? So but I think for most of us, like, I would say that 15 to 20 minute mark is when, like, if you're in a and it depends on where in your zone you are. So like if my finger goes, well, let's do this. My finger, like, this is full range of motion and this is full range of motion. Depending on where you are in that zone, it's going to be more or less tolerable. Those middle ranges are going to be more tolerable to handle for longer periods of time than those end range of motion positions. So kind of avoiding that would be one thing to help you there. Now, then regular thoracic exercise. So I'm a big fan of like the open book, so lying on your side and just doing good thoracic rotation and combining that with thoracic extension, whether that's over a foam roll or things like that on a regular basis. That's one of the beauties of swimming, is that it kind of maintains that extension and rotation of the thoracic spine. For the neck, when you look at the data on like kinesiology or biomechanics, I forget the percentage, but you're adding several pounds for every inch that your head is away from like an optimal posture. You're adding, sorry, I raised my hand apparently. You're adding several pounds of force to the muscular requirements to that. Not only that, you're putting your muscles in a position where they're at the, like, muscles work on a bell curve, right? So at the ends, they have a decreased ability to handle a higher load, and that gets higher in the middle. So the farther I get here, not only am I adding weight, but I'm taking my muscles to an end range where they're not as strong.
Right.
So
you're making them work harder in a less efficient posture.
Yeah. So from that standpoint, though, so that's like ergonomics. But then for most neck conditions, it's been shown that upper quarter strengthening and then just general neck strengthening are helpful in chronic and persistent neck pain issues. So this, again, it kind of goes back to the stronger you are, the harder you are to kill.
Sure.
A little bit. You know, the higher load you can handle at any one time means that your little loads that you encounter day to day are a smaller percentage of that. So
okay. So is this where you would get into, you know, there's an exercise where you take a resistance band, wrap it around the back of your head, and literally pull your head back? Is that the kind of thing you're talking about for
one
strengthening?
Yeah, so that's one thing. You could do isometrics for your head and neck, but then just upper quarter strengthening. So almost think of like I's, T's, and Y's. I's, T's. Well, it would be I's, T's, and Y's. Your good rows, push-ups, that type of thing. That's just strengthening your upper body generally, and particularly your like muscles around your shoulder blade is helpful in a lot of those neck conditions because there's a huge interrelation between your neck musculature and your shoulder. So, and often we're working here, and so what it ends up doing is you end up trying to get those neck muscles to kind of like try to work overtime and that type of thing, and they're trying to stabilize your shoulder, and it's just not working. And is that kind of what you're looking at? Yeah,
absolutely.
But generally speaking, though, going back to our original type 1, type 2 musculature, when you're asking type 2 muscles to hold a position for very long, they just don't want to do it. Right. So when you're asking your traps to stay here, or if you're asking your traps to and your neck extensors, the larger ones, to hold this position for 2 hours, that's just not what they were made to do.
Right.
And so being cognizant of that, again, even if it's just being able to move regularly, and integrating, I hate the term, but they call it movement. Some people call it movement snacks. You know, instead of snacking around the day, I find the term irksome, but that's just me. So, but you're just integrating movement throughout your day is one of the best things that you can do just to stay healthy. Yeah.
That's great. And so thank you so much for talking about this. If people do have specific questions they want to discuss, does your practice have a website where they could find you?
Yeah, we do. So it is it's a long term, and I regret it now, but it's resilientphysiosterling.com. Or if you looked up Resilient Physiotherapy and Performance, that would be us, and we're in Sterling, Colorado. So yeah, I'm always open to, I need to be better about responding to email, but you know, don't we all?
That's all right. That's
right.
A common issue.
But yeah, these are the kind of conversations I love having of just general, like, what are we doing to manage stress and the strain and in our lives, and what I've become more aware of over the last several years is the amount of impact that just general stress has on the physical body. Is you can't discount it. Whether it's emotional, social, spiritual stress, all these things have a huge impact on our physiology. And so yeah, it's all good.
Yeah, great.
That's really good. Thank you so much for talking to us today. This has been really, really beneficial to me personally. Hopefully it will be to our listeners. I'm sure it will be.
Hope so.
Yeah,
and,
well, I hope so.
And maybe some of the exercises we talked about, you know, if you've got some video or some images on how to you know, how to execute those, we could throw that up on the blog.
Yeah, I'll see what I can find, and just holler at me, and I'll try to get those to you.
Sounds great. Thanks so much.
Tony, nice to meet you.
Yeah, nice to meet you too.
All right, y'all have a good one.